Hi, BISC2020 students. Today I'm going to be finishing up part 2 of chapter 17, Diseases of the Skin. Um, we're going to talk a little bit about gangrene, herpes viruses, measles, and then just a few others. So there's going to be quite a few organisms we're going to talk about. We'll cover the who, what, where, when, why, all that stuff for each one. So I got a couple questions from students to kind of go back over Pseudomonas and the information associated with Pseudomonas wound infections. So I'm going to do that really quick and just kind of give you the key info here. So Pseudomonas aeruginosa is the organism. It's gram-negative. Let's see, the people that are affected by this could be anybody because remember, it's an opportunistic pathogen. But people that have skin abrasions, burns, deep wounds are a bit more susceptible than a healthy individual, right? Opportunistic pathogens really only take advantage of already weakened in terms of their immune system or just overall their body is just kind of is not as able to withstand an infection. So people that have wounds, burn victims, cystic fibrosis patients, people that have other problems. There's a short incubation period of up to about between 1 to 3 days. The signs and symptoms, so this is a wound. What you're going to see is the really big one is the blue-green pus. Remember I mentioned pyocyanin, which was a pigment, a green pigment that can occur. We call it blue-green pus when we see the infection. So you would see inflammation, which would be, swelling, warm to the touch at the wound site. You would possibly see the blue-green pus that is not always there, but if it's a deep infection and it's kind of really taken hold, pyocyanin will actually cause this blue-green pus. If the wound isn't treated, we could run into a whole bunch of other issues. We'll get to that in a minute. The cause of the symptoms, I mentioned that there are enzymes that break down tissue. They make endo and exotoxins. These guys are unique in that they make both exo and endotoxins, and they're really good at forming biofilms. Right? We talked about biofilms on catheters, on heart valves that are being replaced. So, yeah, the exo and endotoxins as well as the enzymes help break down tissues. There's a lot of strains that we've found that are antibiotic resistant. That is one of the big problems with this organism. So resistance to antibiotics. How do we diagnose this? Basically, since it's a wound infection, you look at the wound. Makes sense, right? And it makes it a lot easier if you're looking at the wound and all of a sudden you see blue-green pus, right? That's a clear indication it's a Pseudomonas infection. But it doesn't mean it's always there. So if it's not obvious blue-green pus, Pseudomonas infection, what would you do? Well, to diagnose it, you'd have to actually take a culture of the wound itself, okay? And then you would gram stain, you'd use different serological and immunological techniques. Remember we said agglutination and ELISA methods. So those are many ways. There are several ways to diagnose this other than visual assessment. Treatment, as I said, that there are many strains that are antibiotic resistant. We usually try broad spectrum and narrow spectrum. So we start with broad and then we go down to narrow spectrum. However, there's something we have to do first before we actually give antibiotics. We have to go through a process called debridement. It's called debridement. And basically what that is scraping all the dead tissue out of the wound, because all that dead tissue is infected. So when you have a wound like this, they will open it up even more if they have to, and they will flush it with saline solution, which is basically salt water. They will flush it with antibiotics as well. And if there's still tissue that's dead and it's decaying, which means it would typically look black or dark brown, they will literally remove that. They'll scrape it out of the wound. So the process of debridement is literally scraping out dead tissue. And this happens not only for Pseudomonas infections, but we'll talk about gangrene in a minute, and how debridement is essential for gangrene as well. Because if with Pseudomonas, if you don't clear the infection, if you don't clear all the dead tissue out, which has all the pathogens in it, all the Pseudomonas in it, it can get into deeper tissue and then eventually jump into the circulatory system, the lymphatic system, and then travel throughout the entire body. So very, very important that we debride the wound, scrape out all the dead tissue, and then give, depending upon if it's a resistant strain of Pseudomonas or not, usually you start with a broad spectrum and then maybe a more narrow spectrum later on in treatment if it's not getting better. Other information is just that there's a lot of resistant strains, and the blue-green pus is really unique to this. It can also cause otitis media. If you recall, otitis media is middle ear infection. So we also call it swimmer's ear. So Pseudomonas is not just wound, but it can also cause ear infection as well. All right, so for the other, blue-green pus, resistant to antibiotics, can cause otitis media, right? All these things are key traits, and it's really good at forming biofilms. Okay, so hopefully that clears that up. There were some students that wanted me to go back over that and list everything again, and that's fine. If you have further questions on this organism, just shoot me an email. Let's talk about gangrene for a second. So gangrene is pretty nasty. Basically, it's a bacterial infection that causes what we call tissue necrosis. If something is necrotic, it means there's no blood getting to that area and the tissue just dies. So here's some really just interesting points about gangrene in general. There's a couple different ways to describe gangrene, but we're going to focus on Clostridium perfringens. Clostridium perfringens. That's the organism we're going to focus on. It's usually that organism that causes gangrene. But the blood vessels are damaged, which means the extremities in most cases, fingers, toes, are not getting enough circulation. Therefore, the tissue literally dies, and it has to be removed. So they're starved for oxygen and nutrients. Necrosis just means tissue death. Typically, the extremities are more susceptible to this, especially if you think about it. Think about frostbite, for instance. You're out in the cold, your body is freezing, and let's say you just need to survive. What the body does is it starts to bring the blood, most of it, to the vital organs, which are in your chest, your brain, your liver, all those kidneys, and less blood will go to your extremities, which is why typically your fingers and toes get really cold first. And if you stay that way for long enough, the blood continues to mostly stay where the vital organs are, and then you start to have necrosis of the tissue, meaning they're not getting enough oxygen and nutrients, and they die. For gangrene, typically, since we're going to focus on Clostridium perfringens, we're talking about endospores from, let's say, stepping on a nail or cutting your foot on something that's rusty. Clostridium, we know, is found in soil and water in many cases, most Clostridium species. Again, they infect deep tissue. This is not superficial. It may start superficial, but it is, by the time you realize how bad it is. So for instance, if you look on the right here, the top of this person's foot, obviously the toes are bad, but if you look right in the center of the foot, that doesn't look bad. However, I guarantee you, if they were to open this up, there would be absolutely necrotic tissue underneath it, because this affects deep tissue first, and it starts to just eat away everything underneath your epidermis or your dermis. The bacteria, in all of its processes, starts to release really nasty smelling gases as byproducts of cellular metabolism. And when I say nasty, I can withstand most smells, but the first time I ever came in contact with a patient who had necrotic tissue, and it was on their left toes, and it was actually the same toes, the big toe and the second digit, but on the left foot. And it is a horrible smell. And as soon as you walk in, it has just this, you know what it is when it's happening, because of this, the gas that the bacteria are producing as a byproduct of degrading the tissue. If it's untreated, the bacteria can jump into the bloodstream, travel throughout the body. Remember, Clostridium will produce some specific enzymes that will help destroy tissue. So that can travel throughout the body and cause more severe issues elsewhere. But isolating in one spot, so for instance, this patient's foot right here, chances are this patient is going to lose this foot. Because you can see, this, even though the toes are the most severe, the first two, look how swollen the whole foot is, right? And then this part right here tells us there's already necrosis in the center of the foot. So this patient's probably going to lose the foot at the ankle at least, maybe the knee if it's at the knee if it's worse than this. And also because you can see on the outside of the pinky toe here, there's even more necrosis. Okay, so this patient obviously is not going to keep this foot, unfortunately. Now, when it comes to gangrene and wounds that have formed, like the one in the center of the foot here, so let's say the toes were perfectly fine, all the other tissues were fine, it was just this spot in the center for a patient. To try and clear that infection, they would have to debride the wound. So they would lance this, they would take a scalpel, they would open this up even further, this wound right here, because it's not very big. So they would open it up, and then they would spread the skin apart, they would expose the underlying tissue, and they would scrape away all the dead or decaying tissue, and then flush it, and then scrape, and then flush it, and scrape, and so on and so forth until all the dead tissue is remaining. Because remember, if you leave any endospores, if they have favorable conditions, they will germinate, and they will end up being active again. So it's really important that the debridement process removes all traces of that pathogen. So this is the one we're going to focus on right here, Clostridium perfringens, which is one of the organisms that causes gangrene, gas gangrene, what we call gas gangrene. There are others. This is one of the more common ones. So who can be affected? Really anybody can be affected. It's present in soil, water. In some people, it actually can be part of your GI tract. But if you're healthy, it's really, you don't have to worry too much. And not many people are, but some can be. But soil and water, definitely, this is where you're going to find that. And anybody who comes in contact with contaminated soil and water are at risk if the bacteria or the endospores themselves enter the body. There is a short incubation period of 1 to 3 days before you become symptomatic. And that makes sense if you think about if it's in an endospore form, right? The cell has to germinate, meaning it has to build the rest of the cell again, and then become active. So that takes a couple days. It's not something that happens within hours. It takes a few days. Symptoms associated with this is severe pain. You have to imagine it's destroying underlying tissue, which has a lot of peripheral nerves in them. So it's damaging that. So it's severe pain. Wherever the wound is, you're going to have swelling. You're going to have swelling. Because it's an infection, you should see a fever. Before you see necrosis, you can see that the skin actually almost turns purple. And that's partly due to pressure. Imagine you have your thigh, for instance. In your thigh, you had some puncture wound with a nail. It's fine. It was removed. You didn't need stitches. You put some topical antibiotic on it. You put a Band-Aid on it. Boom. You think you're good. But several days later, you start to feel that there's pressure building underneath your skin. And what that is basically the gas that the bacteria is producing as a byproduct of damaging your tissues. So it'll swell and it'll actually have almost like gas bubbles under the skin. And then when they lance it, when they take a scalpel and cut it open, basically it's just your skin, and then it looks just completely black, dead tissue because of the necrosis. That's a really severe form of that, but it can happen. Something else that can happen that's serious if you don't get it under control, you can have hypotension where you have a drop in blood pressure, which is very dangerous, and then could progress even further to shock, septic shock, and then eventually death. The cause of the symptoms, well, the endospores allow it to survive in harsh conditions outside the body. Once it gets inside the body, it produces some enzymes, some other proteins that help destroy the tissue. Diagnosis. First off, it's visual. So with every organism we've talked about here, you always want to take a comprehensive patient history. Knowing that they stepped on a nail or had a nail puncture their leg. That's really important because that then tells you, okay, well, wow, could be Clostridium perfringens, could be Clostridium tetani, could be Clostridium botulinum. It could be so many others as well. So taking a comprehensive history is really important. You're also going to look at the wound itself. Is it necrotic? Does it look like all those features that I listed earlier? Inflamed, darkened skin. Is there a smell? Does it look like it has gas bubbles under the skin? And then additionally to help diagnose this is going to be culturing. You're going to go in after you open the wound up, and you're going to swab it, and you're going to look for endospores. You can do endospore staining. You can do serological or immunological testing, ELISA, agglutination, and you can do those things in order to identify Clostridium perfringens itself. Treatment. So treatment, I've mentioned this already, is debridement, and then treatment with. Now you're going to want to be really aggressive with this and give IV antibiotics. Also, when they debride the wound, they constantly flush it with normal saline, and in some cases directly with an antibiotic. So they'll scrape out the dead tissue, they'll flush it, and then they'll scrape some more and flush more, and then at the end, sometimes they can actually flush it with an antibiotic as well. But usually you're going to give IV antibiotics. So debridement, antibiotics. If it is extremely bad, amputation. If the damage is extensive. One thing that's pretty cool is I've seen this done once. I wasn't part of this process, but working in the hospital, I've seen it done once. They use what we call oxygen therapy or hyperbaric therapy. Basically, you're in a pressurized chamber and you breathe in a large amount of oxygen. Now, Clostridium in general is anaerobic. So if you're in a pressurized environment with lots of oxygen, increasing oxygen levels in your tissue, it is going to slow down the actual growth of this organism. So that's a really cool way. I've only ever seen it done once. I'd imagine that if it was a more severe case, for instance, a whole leg, they're just going to amputate, right? But this is a really interesting way, a hyperbaric chamber, where you're just getting excess oxygen into your body, into the tissues, in the environment, which will slow down the organism because Clostridium is anaerobic. Right? All right, so for gangrene, that's really all I have. There's really no other specialized information that I want to share with you about this. Most of what I shared is right on point. So yeah, that's Clostridium perfringens and the ability to cause gas gangrene. This is not the only organism that causes gangrene, but it is one of the more common ones. All right, so my next slide is going to show you some images of gas gangrene. I'm going to warn you, not a pleasant thing to look at, but if you're going into the healthcare field, you never know what you may come across. So just giving you a little heads up. So on the left here's where it looks like those bubbles of oxygen underneath or bubbles of gas underneath the skin. This whole limb right here, obviously from here down, has necrotic tissue. What they've done is they've opened it up, they've gone through the debridement process, and then they can't close it all the way because if they have to get back in, they will be able to get back in a lot more easily than if they close it all the way. Plus, you have to allow for the gas to escape and several other things. On the right, this is how a typical surgical procedure would work to get rid of gangrene. They open up the whole limb right here. Okay, they flush everything out. They scrape all the dead tissue out. And then they suture it back in place, not closing it all the way, because if you close it all the way, and if there's still bacteria in there, what's going to happen is it's going to end up with like the picture on the left again. So you leave it open, you let it heal for a little while, and then you can see here that it's healing a bit, and then you start skin grafts to replace the missing areas. So this is a pretty serious disease. I know it's not pleasant to look at, but it's always something that you should keep in the back of your mind when it comes to, rusty nails, old glass, cuts, and wounds of that nature. And if not for Clostridium perfringens, but also for Clostridium tetani and Clostridium botulinum. All right, so I didn't include these on the PowerPoint that I posted on Blackboard, so you don't have to stare at them. A simple search of gas gangrene will bring up these photos and others. So I didn't want to have to make you look at them multiple times. Let's move on. Chickenpox. So chickenpox is what we call the varicella zoster virus. It's under the group of herpes viruses. So herpes virus is a big, broad group. It includes chickenpox. It includes something called shingles, which we'll talk about in a minute, or in a little bit. And then herpes virus 1, which is cold sores. Herpes virus 2, which is genital sores. And we'll talk about both of those as well. But chickenpox is simply a disease that typically the people that are affected are young children. So it isn't, the virus is in the herpes viridae family. Who's affected? Children are really affected, but we have a vaccine, so we'll talk about that at the end. So children more likely to get it if they don't have the vaccine. Symptoms, you have a fever and then vesicular rashes that are itchy, so kind of round rashes all over your body that are extremely itchy. As a kid, I got chickenpox, so I remember taking oatmeal baths, and that's something that still is used today, an oatmeal bath, to help ease the itching associated with chickenpox. Cause of the symptoms, the virus enters through the respiratory system, so this is a transmission through respiratory droplets or direct contact with the rash. So the vesicular rash, if you rupture the rash, there's a little clear fluid that will come out of it. And if you contact somebody with that fluid, if they have an open wound, let's say on their arm, and it gets there or gets in their arm or anywhere in their face, it could lead to transmission. Yeah, but mostly it's a respiratory, enters through the respiratory or skin abrasions. So the symptoms, itchy, cause of symptoms, enters the respiratory system, hangs out in the peripheral nervous system. So the nervous system is divided into two divisions, right? We talked about this in an earlier chapter, central and peripheral. Central is all the stuff down the middle, brain, spinal cord, right? And then peripherals everywhere else. So this thing hangs out in the nerves when it's not active. When you first get it, after you clear the virus, it never goes away. Viruses are forever. However, this one can go away and hide for the rest of your life. Reoccurrence of chickenpox is actually very low. If you get it, the reoccurrence of chickenpox itself is pretty low. However, that doesn't mean it can't show up in a different form, and I'll talk about that in a second. Diagnosis, honestly, looking at somebody it's easy to tell they have chickenpox. Clinical assessment, medical history. There is no cure, right? So when you diagnose this, you need to think about, okay, they have this, there is no cure if they have chickenpox, but what we can do is, for treatment, we can use oatmeal baths, calamine lotion to reduce the amount of itchiness associated with these vesicular rashes, which is a good thing, because if you're scratching them and rupturing them and then touching things, you could transmit the virus. And then eventually you could give acyclovir, which is an antiviral, but mostly with chickenpox, you really just let it run its course. Acyclovir is more for people who already have immune systems that are compromised, so they would give acyclovir to somebody whose immune system is a little bit compromised already on top of chickenpox. So healthy individuals usually just let it run its course. It's a couple weeks, usually a couple weeks before it goes away. But just because it goes away from your visual aspect of it, seeing it on your skin, doesn't mean it goes away or out of your body, because it's a virus. It stays with you forever. So diagnosis, clinical assessment, and then treatment is just really treating for to help for the ability to limit the symptoms, like itchiness of the lesions. In some cases, again, you could use an antiviral like acyclovir, which is typically given to more at-risk patients, people who already have immune systems that are taxed or suppressed for other reasons. One other thing that's really important with this is, once this virus, once it clears your skin and all that, it doesn't go away. It actually hides in your nervous system. It hides in your peripheral nervous system. So it goes what we call latent. If you recall the chart that we saw of the stages of disease progression, one of them was latent, and latent means it just hides for sometimes ever. So this disease will go latent. Now, there is a catch. This virus can be reactivated years later, or decades later, or could be, if depending upon your age, could be months later. We really don't have a good idea as to why or when or how it reactivates. But when it does reactivate, it reactivates as something called shingles. Okay, and shingles is, honestly, it looks like a small rash. Usually it's on either the scalp, usually around the elbows, or across the trunk of your body, across your stomach, or on one of the sides of your body. Usually it sticks to just one side, and it looks like a rash, just a bright red rash. However, what it's doing is it's affecting the peripheral nerves, so the rash isn't as itchy as chickenpox. It still is itchy, but it is painful, extremely painful. My wife, who is 36, will be 35, 36 in that range, has had shingles twice over the course of her lifetime. And that's because she has an autoimmune disease already, so she's more susceptible to something like this. So she's had shingles twice. Once on her right side, about just a little bit above the belly button, but more towards the back. And the rash was maybe the size of a $50 coin at most. And she said it was one of the most painful things she's ever experienced in her life. And that includes giving birth. So that should tell you a little bit about how painful shingles actually is. There's a professor in the department here, Dr. Gray, who's a virologist, who is extremely knowledgeable about herpes viruses, including chickenpox and shingles. And he's been working on a vaccine with several other professors at other universities for herpes viruses. It's very neat. He teaches a virology class that's really, really cool. All of this, though, can most likely be prevented if you get the vaccination. There is a vaccine. You get the chickenpox vaccine when you're young. Right? You get the chickenpox vaccine when you're young. If you end up with shingles, you can get another shot, something called Zostavax, which is for people who get shingles at a later age. Now, with Zostavax, the vaccine for when you get shingles, what's interesting is shingles typically doesn't appear in people under mid-50s-ish, mid to late 50s, unless they're immunocompromised. And surprisingly, it's very hard to actually get this vaccine because people that are older and are such a high risk. My wife, for instance, when she got shingles the second time, she had to actually get 2 doctors to prove that it was shingles and not something else before they would give her the actual vaccine for it, which is crazy if you think about it. You have to get 2 different opinions for a vaccine, but when the disease is mostly affecting a much higher age group, and those people really need that vaccine, it does make sense to be a little wary of people having to get that vaccine at a younger age. But still, it was necessary. Knock on wood, she hasn't had it since, but she said it was one of the more painful things she's ever had in her life, and that includes childbirth. So both chickenpox and shingles, not necessarily deadly, but extremely annoying in terms of itchiness, and then painful in terms of shingles. So both of these, and they do affect the nervous system because they hide there, but we put this in with skin infections because it presents as a skin infection. You have vesicular rashes on your body from either chickenpox or the reactivated version of chickenpox, shingles. And you can see here, this is a great image from your book. It talks about how the virus gets in your respiratory system and then replicates and travels through the rest of your body. Lesions on the head, trunk, and limbs. These are chickenpox lesions right here. If you've never had chickenpox, you should be very grateful. It is extremely itchy. It was miserable. The immune system will get rid of most of the virus, but again, I mentioned it goes latent in the peripheral nerves, which are the nerves that are anything other than your brain and spinal cord. So it hangs out in your peripheral nerves, and then if it reactivates later in life, it'll reactivate as shingles. And you can see here, this is roughly, this is the trunk of the body. This is roughly around the belly button, along the back and the side of this patient right here. And it really is an extremely painful rash because it's affecting the peripheral nerves in that area. They call it a banded rash because it does look like a band like this. It stays in kind of this rectangular formation in most cases. But those nerves are super sensitive, and even clothing, just touching it, is extremely painful. But not everybody has shingles, even if they've gotten chickenpox. So it does, just because you get chickenpox doesn't mean you're going to get shingles. You could. It's a possibility. We don't know why it reactivates. We assume that it could be stress, poor diet, poor exercise, lack of exercise, poor health in general. But we really don't have a solid answer as to why and when if it's gonna reactivate. Yeah, and this is just a little bit more info on shingles. I mentioned the rash on the back, the trunk of the body, the back and the side, face, head. My father-in-law had it on his head once. On his scalp. He said that was extremely painful as well. They gave him acyclovir, which I mentioned acyclovir before, as an antiviral. It doesn't make you, immune, but what it does is it usually decreases the length of the actual expression of the virus. So let's say normal expression is a couple weeks. You take acyclovir, and it can actually shorten that a little bit. Doesn't mean it's going to make things completely better, but it could shorten the period of being symptomatic. Yep, painful, burning sensation, and right here, antivirals may limit the outbreak. Can lead to post-herpetic neuralgia. Basically, so post-herpetic neuralgia is essentially this painful condition where your nerves are really sensitive, your peripheral nerves are really sensitive, and it kind of feels like you have shingles constantly. Not very common. More severe cases can have this as a complication. I've already mentioned the vaccines. Yeah, pre-vaccine it was dangerous for newborns and infants, and then immunocompromised people. It was a vaccine. Once the vaccine was developed, chickenpox is a lot less common, and then shingles vaccine. You can see they recommend over 60. That number varies depending upon where you look. If you look at the CDC website versus the actual Zostavax website, the number varies. So we're talking mid-50s and on-ish. All right, human herpes virus 1, HHV1 or HSV1. This is, again, it's in the herpes viridae family, just like chickenpox and shingles. Who can be affected? Anybody. Anybody can be affected. Basically, this virus can be transmitted to anyone. It is a sexually transmitted disease, so the most common way of transmission is going to be through respiratory droplets or saliva or direct contact with an infected person. Now, when you have this, the symptoms associated with it are painful, itchy, and then they're painful, itchy vesicular rashes, or vesicular, not rashes, excuse me, lesions, not rashes, lesions. So basically, it looks like a sore. If you've ever bitten the inside of your cheek or your tongue, if you get a canker sore, for instance, on the inside of your mouth where you've accidentally bit the cheek, the tissue inside your cheek. Those sores like that, imagine them kind of on the lips and around the mouth. These vesicular lesions on the lips, they can be painful, itchy. This is a virus, right? So there's no way to get rid of this virus. We'll talk about treatment in a minute. All right, so symptoms: painful, itchy, vesicular lesions on the lips. Cause of the symptoms: basically the surface of the virus has something called what we call glycoproteins, which help it enter our cells, and then when they're in our cells, viruses replicate, and when they replicate, in this case, the replication process causes the lesions that we see on the lips. This virus also can suppress some of our immune response, so that makes it extremely pathogenic. Those virulence factors are pretty dangerous. All right, so those are the causes of the symptoms. The glycoproteins aid in entry of the host cells, of our cells. The viral replication inside those cells leads to the lesions, and the virus itself can suppress host immune response. Excuse me. Diagnosis. It's pretty easy to diagnose this. When there's an active infection, you can see the lesions on the lips. Sexual history is important, medical history as well. You can also use, you can also test to see if the body has made antibodies against the virus. So our immune system does some amazing things, and one of the things it does is create antibodies. I mentioned antibodies in the past chapters, but I'm going to bring them up again because they're really important. These antibodies are specific to certain antigens. So human herpes virus, remember, as those glycoproteins on the outside? Well, our body would see those glycoproteins and make antibodies against the glycoproteins. Now, you can test the blood to see if those antibodies are present, and that can tell you whether or not a patient has or has had human herpes virus 1, HHV1. It doesn't mean it's an active infection. It could have gone latent, but the presence of antibodies indicates the presence of the virus. There is no cure. There are topical or oral antivirals that will reduce the duration of the outbreak, but there's really no treatment for this. Now, in the U.S., so this is a little bit of extra information on epidemiology. There's about, per year, according to the CDC, about 600,000 new cases a year. And in the U.S., about 60% of the population-ish has or has been in contact with this virus. So we're talking 2/3 of the population, roughly, has or has come in contact with this. It is more of a eyesore as opposed to something that's very serious and can cause severe repercussions in terms of the disease getting worse. So yes, it is unsightly. Yes, it can be transmitted through those vesicular lesions, but it's more just of an eyesore as opposed to something to be overly concerned about in terms of, oh no, do I need to go to the ER? Or, okay, I know what this is. It's going to clear up on its own in a given amount of time. One other thing that's really interesting is it hides in the trigeminal nerve ganglion. So a nerve ganglion is basically a group of nerves or a bundle of nerves that are at a certain area. And the trigeminal nerve ganglion is at your temple. Okay, so your temple has a bunch of nerves that meet on both sides at that spot, and we have what we call the trigeminal ganglion. The HSV1 or HHV1, whichever you want to call it, will, when it goes latent, will travel up the peripheral nerves in the face to the nerve ganglion at your temple, the trigeminal nerve ganglion, and it'll hang out there. You may never in your life have a expression of this virus. So you could get this virus and never ever get a cold sore in your entire life. Doesn't mean you don't have the virus, but it just means it is latent. Or you can get it and then it can go latent and then it can come back, or it can go latent, or you can get it and it'll go latent and never come back. So there's this ability for this virus to hide after it's been expressed for a while. It can go and hide in the trigeminal nerve ganglion. We do not know why it expresses when it does and doesn't express when under other conditions. Again, we kind of assume that it has to do with overall health, your immune system. Are you overweight? Do you smoke? Things like that. Overall health kind of is one of the factors that we look at, as well as age. And we expect people who are a little bit older to have a greater risk of reactivation. Excuse me. Again, this is something that is very, very, very common. Now, here's where this shows you, these are the lesions, the vesicular lesions on the lip, okay? And then it enters your body through, remember, respiratory droplets or direct contact with a lesion like this. Can go from the face peripheral nerves and hang out in the trigeminal nerves, which is roughly right around your temples. And it just hangs out there. And then if it ever gets reactivated, it comes back down the peripheral nervous system to the lips, and you get another cold sore. And then if it goes back to latent, it'll go back to the trigeminal nerves, the nerve ganglion, hang out there, and may never come back. Who knows? We don't really know. So this is human herpes virus 1, HHV1. It was also called herpes simplex virus. Now we refer to it more as human herpes virus, HHV1. You may see it as HSV1, same thing. We're talking about herpes virus 1, which is cold sores. Herpes virus 2, I'm not going to put a whole slide about who and all those other bits of information, because it's pretty much the same thing as herpes virus 1. The big difference is it hides, herpes virus 2 is genital herpes. So 1 is oral herpes, mouth, and then 2 is genital herpes. And what will happen is almost this exact same process where if somebody has HHV2, they can have an outbreak on their genitals, and then that outbreak clears up and the virus travels back up the peripheral nerves to a nerve ganglion at the base of your spinal cord. So right about where your tailbone is, a little bit above that, your sacrum, there's a nerve ganglion. And that's where HHV2 hides. So HHV1 hides in trigeminal. The HHV2 hides in the one by the sacrum, down by the base of your spinal column. And it does this exact same mechanism where it will show up, have an outbreak, and then it will heal, and then it hides. It may come back and activate again at some point. Who knows? It may never come back. But in HHV2, where it hides, is just a different location because it affects a different location. And HHV2 affects the genitals, as opposed to HHV1, which affects the mouth, which is oral herpes. Now, I get a lot of questions about this. Somebody has herpes, genital herpes, and they sit on a toilet. Can I sit on the toilet too? Yes. You can sit on the damn toilet. Okay? Viruses cannot survive outside host cells for very long. Some can survive a decent amount, but herpes viruses, they're not going to survive on a toilet seat for extended periods of time. If somebody has a cold sore, maybe avoid sharing the same drink, because any backwash could have viral particles in it. Avoid kissing because there's a risk of transmission. Doesn't mean you're going to get the virus. It just means you could. There's really no way to be sure unless you have extremely dry, cracked lips, which provides multiple ports of entry for the virus. Kissing someone who has this, yes, there is a risk to it, but as long as your lips are not cracked and dry, the risk is lower than if they were dry and cracked. So anyway, the point is this virus is unique and is very interesting in that when it goes latent, where it hides, depending upon whether it's HHV1 or HHV2. Measles. So measles is an interesting virus, and it's not part of the herpes viridae. It's actually part of the Paramyxoviridae family. So measles, or rubeola, this is something we really haven't had to worry about until recently, within the last 5 years or so. And we hadn't seen cases of measles, or the number of cases that we've seen over the last 5 years for a very long time, because we have a vaccine for it. This vaccine is given when you're really young. So measles was considered eradicated in the United States, meaning there was less than, I believe it's 100 cases per year for a whole year. So there was less than 100 cases for an entire year. So it's considered eradicated in the U.S. However, this is where this famous paper that was published about the vaccine for measles, the MMR vaccine, the mumps, measles, and rubella vaccine, where the scientist made up data. He linked it to autism, and a celebrity got behind it with their platform of millions and millions and millions of fans, and started spreading that the vaccine for measles caused autism. Now, 20-something years later, we're still facing the effects of that falsified research paper. it was not peer reviewed. It was not. It was not a really sound scientific experiment. The guy who did the experiments, he got in so much trouble. He lost all his credentials. At one point, they were even considering charging him with manslaughter, because obviously this affects other people, and it was killing people. So anyway, this one paper, which eventually was disproved by numerous scientists and numerous research studies that proved he made everything up, and they even admitted it. But the damage was already done. It was already done. It had spread, and it continues to spread, which is one of the big issues now with the anti-vaccination movement. Is they cite this specific paper about MMR, which prevents measles. They cite this particular paper, even though it's completely wrong. I will tell you 100% right now, there is zero, and I mean literally zero, scientific evidence that links vaccinations and autism. And something that was really amazing is last year or the year before, in Europe, they did, I want to say it was the Netherlands, they had a 10-year study where they followed 650,000 people who got the MMR vaccine. And of that, only about 1,500 people had autism. Now, out of 650,000 people, you are bound statistically to have some people who are just genetically predisposed to having autism. There was no statistical significance between the virus, or the vaccine, against the virus, and linking it with causing autism. I bring this up and I stress this a lot because the measles is something that was gone from the US. We had beat it, but now it is back, and it is it's causing serious issues around the US. Obviously, right now we're focused on coronavirus, but measles is still extremely dangerous, and it's something we have to worry about as well. So who can be affected by this? Anybody, because it's highly contagious. It is highly contagious, so it spreads very quickly. Healthy individuals, less likely to have complications, but they can still, this is a true pathogen. You can still get sick from this. The incubation period for this is about 8 to 12 days, roughly. And the symptoms are fever, sore throat, dry cough, something called a Koplik spot, Koplik, Koplik spot. Basically, a Koplik spot is red spots or little circular rashes, circular spots that have a white dot in the very center, and they're found in the mouth. And that makes sense because the transmission is through respiratory droplets, right? So respiratory droplets, you're going to breathe that in and through the mouth and nose down into the lungs. So Koplik spots, these red spots with white dots in the center, can be found in the mouth, and you'll have a red rash on the face. It starts on the face and then it moves down the rest of your body. The cause of the symptoms, couple things. It causes cells to fuse, which allows it to hide from immune cells. And then cytotoxic T cells, our cytotoxic T cells, kill any of our cells that are infected. So cytotoxic T cells are pretty amazing. They can look at a cell, a host cell, our own, and say, okay, this one is infected with the virus, let me kill it. And the cytotoxic T cell will kill the infected host cell. However, when it does that, it promotes symptoms and lesions associated with the virus, okay, because it's killing the host cell, but it's now releasing a bunch of viruses and viral particles into the to spread throughout the body. So cytotoxic T cells doing their job actually hurts humans more. It promotes symptoms and lesions on the body. The immune system can be suppressed as well by this virus. This is very, very dangerous, very contagious. Diagnosis, medical history, clinical evaluation. You can look to see if there are antibodies, if our body has built antibodies against it. So remember, even if you don't have an active infection, if it's in your body's going to build antibodies against it. If we detect antibodies, then we know you have the virus or come in contact with the virus. There is no cure. So diagnosis, right, is going to be looking at the patient and then medical history, especially travel history in the U.S. If you're traveling to certain parts of the globe, measles is still a huge problem and kills thousands of people a year in certain regions of the world. So travel history is actually kind of important as well. And then treatment. Well, first off, we can prevent all of this by getting the MMR vaccine, right? By getting the MMR vaccine, we can prevent measles. However, if you don't get the MMR vaccine, A, there's no cure, and B, the only way to really treat this is supportive therapy only. Basically, treat the symptoms. Make the patient comfortable. Treat the symptoms, because there is no way to treat this or to cure this. Excuse me. So anyway, measles, very, very contagious. Under the other category, I guess you could say that we had eliminated this virus in the U.S., but it's now back because people are not vaccinating their children against this virus, even though we had eradicated it at one point in history. So, obviously, that's a big problem. And one of the worst things about this whole anti-vaccination movement with the MMR vaccine is they target immigrant populations. So, for instance, there were cases in Minnesota, which was where the actual what we call hotspot was, where the big outbreak was in Minnesota, was an immigrant community. I can't remember where they were from. I want to say somewhere in the Middle East, but I don't remember the exact location. Anyway, they target immigrant populations. There was a outbreak in New York within the Hasidic Jewish community in New York, where they had anti-vaccination. People had gone in, talked to these people in those populations, and convinced them not to vaccinate. And then they saw huge increases in number of cases of measles. There's a lady in Canada as well who had something like 7 or 8 children, and she didn't vaccinate them, and then several of them died, and then she finally vaccinated the other ones. So again, this is a very dangerous virus. The vaccine for this is very, very important. These are the Koplik spots on the top here. Red spots with white dots. Red spot, white dot. And then this is the maculopapular rash on the skin. Starts on the face and head and goes down to the trunk and the extremities. Complications, you can see here that how severe, the severity of it. 1 in 4 will require hospitalization. 1 out of 1,000 could get swelling of the brain, which is called, does anyone remember? Encephalitis, right? And then depending on where you live, this number could change, but 1 to 2 out of every 1,000 will die despite care. In the US, this is going to be a little less than this, but in places that have not effectively eradicated measles or decreased the number of cases of measles to significantly less than what we see here in the US, people can die. You have a high mortality rate. There is the MMR vaccine, and then there's a live attenuated version that, remember, if you're giving somebody an attenuated vaccine, a live attenuated vaccine, you can't give it to children, right? Especially, we usually lay the cutoff at about 1 year, 1 to 1.5 to 2 years old, in that range. You really don't give live attenuated vaccines to children younger than 1 year olds because their immune system is not fully developed. But the MMR vaccine is effective. This is a really, really effective vaccine. We've gotten all the kinks out of it. It works. Now we just need to make sure that everybody continues to get vaccinated, which is part of the problem. Fungal skin infections are, this is the last thing we'll talk about, usually superficial. You may have heard of ringworm. Ringworm is not an actual worm. It is a fungal infection. Cutaneous is referring to the skin. So cutaneous mycoses is fungal skin infections. Very superficial. You have dermatophytes, which are associated with your hair, nails, and skin. They become flaky. That makes sense if you've ever had like athlete's foot, for instance. It's itchy, right? In between your toes. So, yeah, cutaneous mycoses. You could have dermatophytes. Candida albicans specifically, which we'll talk about in a minute, is another pathogen. It's a yeast that will cause cutaneous mycoses. Treatment for it in general: get the affected hair, remove that, and then topical or oral antifungal medications. As a kid, ringworm is something that lots of people get when they're in daycare or in, preschool, first grade, all that, because there's so many kids in such a small area. Ringworm is just, it's a fungal infection, a cutaneous fungal infection that can be treated really easily. It's not something that is is going to cause death necessarily. I used the term dermatophytes before. Derm is referring to the skin. Basically, that's just a group of fungal organisms that cause issues with skin, hair, and nails. That's just basically what a dermatophyte is. I'm not going to go into it any further than that. So yeast infections, the etiological agent, Candida albicans. This is one of the most common, if not the most common. It's Candida albicans. It's a unicellular yeast, and it is part of the GI tract and the skin of humans, especially women. Candida albicans is one of the primary organisms that colonizes the female vagina. Okay, so it's Candida albicans, and then it's also lactobacilli that colonize the vagina. The lactobacilli keep the Candida in check, though, which prevents yeast infections. We'll get to that in the next chapter. But you can see here, Candida albicans can cause diaper rash. This is more cutaneous candidiasis. You're talking about just a flaky, itchy fungal rash. Lots of places you see this is where you sweat more, your underarm, under the breasts, between your thighs, for instance, where you have these friction-prone folds. Treatment: dry it. If it's a child, diaper changes and then topical creams usually work really well. This is not something that you usually get hospitalized for unless it turns into something more severe like thrush, which I'll talk about in a minute. Signs and symptoms here for just general cutaneous candidiasis is a bright red macular rash. The rash is itchy and flaky. Sometimes I've only seen small white pustules maybe once or twice on cutaneous candidiasis, but more associated with something called thrush, which is also caused by Candida albicans. So cutaneous candidiasis, who is affected? Anybody. It's an opportunistic pathogen. So anybody can be affected by this, but people that are more susceptible, right? Weakened immune system. They have hyperhidrosis, meaning they sweat profusely, making those areas, the armpits, for females under the breast, between the thighs, higher risk due to friction and the sweat. Symptoms: a red macular rash, basically, that can be really itchy, flaky, can burn. The cause is the Candida albicans makes a bunch of adhesion factors that allow it to attach to host tissues, and then it breaks down keratin to invade the skin. So our skin has a layer of keratin on it, which is a bunch of dead cells, and it helps waterproof and leak-proof our skin. The Candida albicans has adhesion factors that allow it to attach and then eventually break down the keratin so it can get into the epidermis and the dermis. If it goes any further, it can go from the epidermis to the dermis. So those are the causes. Diagnosis: looking at the rash, it's pretty obvious if it's flaky, if it's in a location like on an infant on the butt or between the butt cheeks, inner thighs, armpits, very common. You can culture it and look at it under a microscope. If you see it under a microscope, it looks really interesting. I don't have a photo of it, unfortunately, but it does not look like bacteria at all. You guys should have seen some examples of fungal infections or fungal slides when you use the microscopes early in the semester. So you can definitely tell a bacterial infection versus a yeast infection pretty easily under a microscope. Let's see, you could, in terms of treatment, it usually resolves itself, or you could use antifungals. There's creams, ointments, or even oral medication that you could take. Usually, antifungal creams and ointments are enough, but if it's severe enough, they will give you topical and oral antifungals, which will help treat that rash. Now, there, in this other category at the bottom here on this slide, there's a couple things I want to point out. I mentioned that it is Candida albicans is an opportunistic pathogen, and it's found in the female vagina. It's a part of the normal microbiota of the vagina. Now, what's interesting is also in the vagina is bacteria lactobacilli. And what happens is lactobacilli produce lactic acid as a byproduct, which kills Candida. So when the lactobacilli are out-competing Candida, you have no problems. You don't run into any issues with infections usually, if you're healthy. But when, let's say, you take antibiotics and the lactobacilli concentration drops, if it drops too much, what's going to happen is Candida will outcompete the lactobacilli, and it will take over, and it'll cause the yeast infection, which is actually quite common with women who, when they take antibiotics, they also end up with a yeast infection as well, and need to be treated for a yeast infection, in addition to taking the antibiotics for whatever the other infection might be, the bacterial infection. This is something that actually happens quite often. A female taking oral antibiotics, the lactobacilli in the vagina, the number of cells drops, Candida outcompetes it, and then all of a sudden takes over and then causes a yeast infection. Once the antibiotics are completed, though, and antifungals are being taken, the lactobacilli then reestablishes itself as the dominant organism in that environment, and the yeast infection is gone, and everything is back to normal. This happens with females who take antibiotics. It also happens commonly with women who enter menopause, because estrogen plays a really important role in lactobacilli concentration. The estrogen gets broken down and is used by the lactobacilli, but all of a sudden during menopause, that the estrogen concentration drops, which means the lactobacilli concentration drops, Candida increases, and causes a yeast infection. That's one of the reasons why women who go into menopause end up getting yeast infections a little bit more commonly than younger women. And then lastly, this organism can cause a disease called thrush. Okay, so it can cause something called thrush, which is common more in children. Basically, it's an infection. It's a yeast infection in the mouth. I mentioned earlier canker sores, where you bite the inside of your cheek and you get one of those bad sores. Imagine that in the mouth times 100. Hundreds of them possibly. That is thrush, oral thrush. It is horrible. It happens in young children sometimes, less frequently in adults. I have actually had thrush before. I was 21, 22. I had my tonsils taken out, and I left the hospital after my tonsils were taken out. The stitches ripped. I went back into the hospital because it was bleeding, wouldn't stop bleeding. So back into the hospital a day later. They did the surgery again. I went home. About 5 days later, I had those sores in my mouth, on my lips, on my tongue, and then down the back of my throat partially. And you could look at them, you could open your mouth, and you could see them all. And what's interesting is because thrush is not very common in adults, my physician My family physician had no idea what it was. A second doctor had no idea what it was. It was actually a good friend of ours who was my dentist who knew exactly what it was when I told him what was going on. And he's the one who actually treated me with antifungal medication. And then because I couldn't eat or drink anything because it was too painful, Vicodin and then a lidocaine mouthwash that numbed my mouth and throat so I could actually get some food down. That was a very crazy infection that I had never seen, and it lasted for about a month, and I lost significant amount of weight, a very, very unhealthy amount of weight, because I could not consume anything because it hurt too much. I would have to rinse my mouth with lidocaine, which is a numbing agent, just to drink water. So this organism, yes, causes cutaneous candidiasis, but it can also cause more severe diseases if it's able to. It is very entrenched in its ability as an opportunistic pathogen to cause infections. Most of us, healthy, don't have to worry about it too much, but those that are susceptible, this is something that could happen. This chart shows you virulence factors for Staph aureus. I talked about Staph aureus and strep pyogenes early in this chapter, in part 1. I mentioned pretty much all of these. Coagulase, catalase, exfoliative toxin, hyaluronidase, hemolysins, M protein. So I've mentioned a lot of these virulence factors, and I want you to know which ones go with which, okay? It's very important that you know this, because when I give you a case study, I may say they tested for toxins and found a exfoliative toxin or a hyaluronidase, which is an enzyme. Or I could say they found the M protein. So you need to know the ones that I talked about earlier in part 1 of this chapter. And it was definitely coagulase, catalase, exfoliative toxin, hyaluronidase, hemolysin, and M protein. The ones I didn't talk about really were pyrogenic and lipases. Those are the two that I really didn't mention, which you can ignore them then. So that's the end of this chapter. I know I went a little over, more than I expected, but that's okay. That's why I broke this up into 2 parts. All right, have a great day. Stay safe, and we'll meet again next chapter for urinary system and reproductive system diseases. Hope you all are staying safe, and we'll talk soon.